Chapter 2: Mental Health and Mental Illness: Historical and Theoretical Concepts. The consideration of mental health and mental illness has its basis in the cultural beliefs of the society in which the behavior takes place. Some cultures are quite liberal in the range of behaviors that are considered acceptable, whereas others have little tolerance for behaviors that deviate from the cultural norms. A study of the history of psychiatric care reveals some shocking truths about past treatment of individuals with mental illness. Many were kept in control by means that today could be considered abuse. This chapter deals with the evolution of psychiatric care from ancient times to the present. Mental health and mental illness are defined, and the psychological adaptation to stress is explained in the terms of two major processes: anxiety and grief. Behavioral responses are conceptualized along with the mental health/mental illness continuum. Historical overview of psychiatric care. Primitive thoughts regarding mental disturbances varied and were often rooted in cultural and religious beliefs. Some cultures thought that an individual with mental illness had been disposed of his or her soul, and wellness could only be achieved if only the soul was returned. Others believed that evil spirits or supernatural or magical powers had entered the body. The cure for these individuals involved a ritualistic exorcism to purge the body of these unwanted forces. This purging often consisted of brutal beatings, starvation, and other torturous means. Still other cultures considered that the individual with mental illness may have broken a taboo or sinned against another individual or god, for which ritualistic purification was required or various types of retribution were demanded. The association of mental illness with demonology led to some individuals with mental illness being executed. These ancient beliefs dwindled with increasing knowledge about mental illness and changes in the cultural, religious, and socio-political attitudes. Around 400 BC, the work of Hippocrates was the first to place mental illness in a physical rather than supernatural context. Hippocrates theorized that mental illness was caused by irregularity in the interaction of the four body fluids: blood, black bile, yellow bile, and phlegm. He called these body fluids humors and associated with each with a particular disposition. Disequilibrium among these four humors were often treated by inducing vomiting and diarrhea with potent cathartic drugs. During the Middle Ages, the association of mental illness with witchcraft and the supernatural continued to prevail in Europe. During this period, many people with mental illness were set to sea alone in sailing boats with little guidance to search for their lost rationality, a practice from which the expression "ship of fools" was derived. But in Middle Eastern countries, mental illness began to be perceived as a medical problem rather than a result of supernatural forces. This notion gave rise to the establishment of specialized hospital units and residential institutions specifically designed for clients with mental illness. They can likely be considered the first asylums for individuals with mental illness. Colonial Americans tended to reflect attitudes of the European communities from which they immigrated. Particularly in the New England area, individuals were punished for behavior attributed to witchcraft. In the 16th and 17th centuries, institutions for people with mental illnesses did not exist in the United States, and care of these individuals was a family responsibility. Those without family or other resources became the responsibility of the communities in which they lived and were incarcerated in places where they could not harm themselves or others. The first hospital in America to admit clients with mental illness was established in Philadelphia in the middle of the 18th century. Benjamin Rush, often called the father of American psychiatry, was a physician at the hospital. He initiated the provision of humanistic treatment and care for clients with mental illness. But although he included kindness, exercise, and socialization in his care, he also employed harsh methods such as bloodletting, purging, various types of physical restraints, and extremes of temperatures, reflecting the medical therapies of that era. The 19th century brought the establishment of a system of state asylums, largely the result of the work of Dorothy Dix, a former New England schoolteacher who lobbied tirelessly on behalf of the mentally ill population. She was unwavering in her belief that the mental illness were curable and that state hospitals should provide humanistic therapeutic care. The system of hospital care for individuals with mental illness grew, but the mentally ill population grew faster. The institutions became overcrowded and unstaffed, and conditions deteriorated. Therapeutic care reverted to custodial care in state hospitals, which provided the largest resource of individuals with mental illness until the initiation of the community health movement in the 1960s. The emergence of psychiatric nursing began in 1873 with the graduation of Linda Richards from the nursing program at the New England Hospital for Women and Children in Boston. She has come to be known as the first American psychiatric nurse. During her career, Richards was instrumental in the establishment of a number of psychiatric hospitals and the first school of psychiatric nursing at the McGlen Asylum in Waverly, Massachusetts. The school and others like it provided training and custodial care for clients in psychiatric asylums, training that did not include the study of physiological concepts. Significant change in psychiatric nursing education did not occur until 1955, when incorporation of psychiatric nursing into the curriculum became a requirement for all undergrad schools of nursing. This new curriculum emphasized the importance of the nurse-patient relationship and therapeutic communication techniques. Nursing interventions and somatic therapies improved impetus for the incorporation of these concepts into the profession's body of knowledge. With the increasing need for psychiatric care in the aftermath of World War II, the government passed the National Mental Health Act of 1946. This legislation provided funds for the education of psychiatrists, psychologists, social workers, and psychiatric nurses. Grad-level education in psychiatric nursing was established during this period. Around the same time, the introduction of antipsychotic medications made it possible for clients with psychoses to be more readily participating in the therapy, including psychological therapies. Mental health. A number of theorists have attempted to define the concept of mental health. Many of these individual concepts deal with various aspects of individual functioning. Maslow emphasized an individual's motivation and the continuous quest for self-actualization. He identified a hierarchy of needs, with the most basic needs requiring fulfillment before those at higher levels to be achieved, and with self-actualization defined as fulfillment of one's highest potential. And an individual's position within the hierarchy may revert from a higher level to a lower level based on life circumstances. A representation of this need hierarchy is presented in Figure 2-1. Maslow described self-actualization as being psychologically healthy, fully human, highly evolved, and fairly mature. He believed that self-actualized individuals possess the following characteristics: an appropriate perception of reality, the ability to accept oneself, others, and human nature, the ability to manifest spontaneously, the capacity for focusing concentration on problem solving, a need for detachment and desire for privacy, an intensity of emotional reaction, a frequency of peak experiences that validate the worthwhileness, richness, and beauty of life, creativeness, and a degree of non-conformance. Jehoda identified a list of 6 indicators that are a reflection of mental health: a positive attitude towards self, growth environment, and the ability to achieve self-actualization, integration, autonomy, perception of reality, and environmental mastery. Robinson offers the following definition of mental health: a dynamic state in which thought, feeling, and behavior that is age-appropriate and congruent with the local and cultural norms is demonstrated. Expanding on this concept, mental health may be viewed as a relative state that occurs along with continuum thoughts, feelings, and behaviors that are all part of the human psychological experience and are influenced by the perceived magnitude of stressors and interaction with adaptive capabilities. In keeping with the framework of stress and adaptation, this text will use a modification of Robinson's definition of mental health. Thus, mental health will be defined as the successful adaptation to stressors from the internal or external environment, evidenced by thoughts, feelings, and behaviors that are age-appropriate and congruent with social and cultural norms. Mental illness. Arriving at a universal concept of mental illness is difficult because the cultural factors that influence such a definition. However, certain elements are associated with individuals' perceptions of mental illness, regardless of the cultural origin. Horowitz identifies 2 of these elements as 1, incomprehensibility, and 2, cultural relativity. Incomprehensibility relates to the inability of the general population to understand the motivation behind an individual's behavior. When observers are unable to find meaning or comprehensibility in behavior, they are likely to label that behavior as mental illness. Horowitz states observers attribute labels of mental illness when the rules, conventions, and understandings they use to interpret behavior fail to find any intelligible motivation behind action. The element of cultural relativity considers that these rules, conventions, and understandings are conceived within an individual's own particular culture. Behavior that is considered normal and abnormal is defined by one's cultural or societal norms. Therefore, a behavior that is recognized as evidence of mental illness in one society may be viewed as normal in another society, and vice versa. The American Psychiatric Association, in its Diagnostic and Statistical Manual of Mental Disorders, 5th edition, also known as DSM-5, defines mental disorder as a syndrome characterized by clinically significant disturbance in an individual's cognitions, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or development processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. In this text, and in keeping with the transactional model of stress and adaptation, mental illness is characterized by maladaptive responses to stressors from the internal or external environment, evidenced by thoughts, feelings, and behaviors that are incongruent with the local and cultural norms that interfere with the individual's social, occupational, and/or physical functioning. Psychological adaptation to stress. All individuals exhibit characteristics associated with both mental health and mental illness at any given point in time. Listed in Chapter 1, the concept of stress adaptation describes how an individual's response to stressful situations is influenced by physiological factors, his or her personal perception of the event, and a variety of predisposing factors. Anxiety and grief have been described as two primary psychological response patterns to stress. A variety of thoughts, feelings, behaviors are associated with each of these response patterns. Adaptation is determined by the degree to which the thoughts, feelings, and behaviors interfere with an individual's functioning. Feelings of anxiety are so common in our society that they are almost considered universal. Anxiety arises from the chaos and confusion that exists in the world. Fear of the unknown and conditions of ambiguity allow anxiety to take root and grow. Low levels of anxiety are adaptive and can provide the motivation required for survival. Anxiety becomes problematic when the individual is unable to prevent his or her response from escalating to a level that interferes with the ability to meet basic needs. Peplow described 4 levels of anxiety: mild, moderate, severe, and panic. It's important for nurses to be able to recognize the symptoms associated with each level to plan appropriate intervention. Mild anxiety. This level of anxiety is seldom a problem for the individual. It is associated with the tension experienced in response to the events of day-to-day living. Mild anxiety prepares people for action. It sharpens the senses, increases motivation for productivity, and results in a heightened awareness of the environment. Learning is enhanced, and the individual is able to function at his or her optimal level. Moderate anxiety. As the level of anxiety increases, the extent of the perceptual field diminishes. The moderately anxious individual is less alert to events occurring in the environment. Their attention span and ability to concentrate decreases, although he or she may still attend to needs with direction. Assistance with problem solving may be required. There is increased muscle tension and restlessness are evident. Severe anxiety. The perceptual field of the severely anxious individual is so greatly diminished that concentration centers on one particular detail only or on many extraneous details. Attention span is extremely limited, and the individual has difficulty completing even the simplest tasks. Physical symptoms include but are not limited to headaches, palpitations, and insomnia, and emotional symptoms that are not limited to but include confusion, dread, and horror may be evident. Discomfort is experienced to the degree that virtually all overt behavior is aimed at relieving the anxiety. Panic anxiety. This is the most intense state of anxiety, and the individual is unable to focus on even one detail in the environment. Misperceptions are common, and a loss of contact with the reality may occur. The individual may experience hallucinations or delusions. Behavior may be characterized by wild and desperate actions or extreme withdrawal. Human functioning and communication with others is ineffective. Panic anxiety is associated with a feeling of terror, and individuals may be convinced that they have a life-threatening illness or fear that they are going crazy, are losing control, or are emotionally weak. Prolonged panic anxiety can lead to physical and emotional exhaustion and can be a life-threatening situation. Behavioral adaptation to responses to anxiety. A variety of behavioral adaptation responses occur at each level of anxiety. Figure 2-2 depicts these behavioral responses on a continuum of anxiety ranging from mild to panic. Mild anxiety. At this level, individuals employ any number of coping behaviors that satisfy their needs for comfort. The following types of coping mechanisms that individuals use to relieve anxiety and stressful events include, but not limited to, sleeping, yawning, eating, drinking, physical exercise, daydreaming, smoking, laughing, crying, cursing, pacing, nail biting, foot swinging, finger tapping, and fidgeting. Undoubtedly, there are more responses, too numerous to mention here, considering that each individual develops their own techniques to relieve mild anxiety. Some of these behaviors are more adaptive than others. Mild to moderate anxiety. Sigmund Freud identified the ego as the reality component of the personality, governing problem-solving and rational thinking. As the level of anxiety increases, the strength of ego is tested and energy is mobilized to confront the threat. Anna Freud identified a number of defense mechanisms employed by the ego in the face of threat to biological or psychological integrity. Some of these ego defense mechanisms are more adaptive than others, but all are used either consciously or unconsciously as protective devices by the ego to relieve mild to moderate anxiety. They become maladaptive when they are used by an individual to such a degree that there is an interference with the ability to deal with reality, effective interpersonal relations, or occupational performance. Maladaptive use of defense mechanisms promote disintegration of the ego. The major ego defense mechanisms identified by Anna Freud are summarized in Table 2.2. Moderate to severe anxiety. Anxiety at the moderate to severe level that remains unresolved over an extended period of time can contribute to a number of physiological disorders. The DSM-5 describes these disorders under the category psychological factors affecting other medical conditions. The psychological factors that may exacerbate symptoms of, delay recovery from, or interfere with treatment of the medical condition. The condition may be initiated or exacerbated by the environmental situation that the individual perceives as stressful. Measurable pathophysiology can be demonstrated. It is thought that psychological and behavioral factors may affect the course of almost every category of disease, including cardiovascular, GI, neoplastic, neurological, and pulmonary conditions. Severe anxiety. Extended periods of severe repressed anxiety can result in psychoneurotic behavior patterns. Neurosis is no longer considered a separate category of mental disorder. However, the term is still used in literature to describe the symptomatology of specific disorders and to differentiate from behaviors that occur at the most serious levels of psychosis. Neuroses are psychiatric disturbances characterized by excessive anxiety that is expressed directly or altered through defense mechanisms. It appears such as a symptom of obsession, compulsion, phobia, or sexual dysfunction. The following are common characteristics of people with neuroses. They are aware that they are experiencing distress. They are aware that the behaviors are maladaptive. They are unaware of any possible psychological causes of the distress. They feel helpless to change the situation. They experience no loss of contact with reality. The following disorders are examples of psychoneurotic responses to anxiety as they appear in the DSM-5. Anxiety disorders. These disorders in which the characteristic features are symptoms of anxiety and avoidance behavior, such as phobias, panic disorder, generalized anxiety disorder, and separation anxiety disorder. Somatic symptom disorders. These disorders in which the characteristic features are physical symptoms for which there's no evident organic pathology. Psychological factors are judged to play a significant role in the onset, severity, exacerbation, or maintenance of symptoms. Dissociative disorders. These disorders in which the characteristic feature is the disruption in the usually integrated functions of consciousness, memory, identity, or perception of the environment. Panic anxiety. At this extreme level of anxiety, an individual is not capable of processing what is happening in the environment and may lose contact with reality. Psychosis is defined as a significant thought disturbance in which reality testing is impaired, resulting in delusions, hallucinations, disorganized speech, or catatonic behavior. The following are common characteristics of people with psychoses. They exhibit minimal distress. Their emotional tone is flat, bland, or inappropriate. They are unaware that the behavior is maladaptive. They are unaware of any psychological problems. They are exhibiting a flight from reality into a less stressful world, or in one in which they are attempting to adapt. Examples of psychotic responses to anxiety include schizophrenic, schizoaffective, and delusional disorders. Grief. Most individuals experience intense emotional anguish in response to a significant personal loss. A loss is anything that is perceived as such by the individual. Losses may be real, in which case they may be sustained by others, as such as death of a loved one, or they may be perceived by the individual alone, unable to be shared or identified by others, such as the loss of feeling of femininity following mastectomies. Any situation that creates change for an individual can be identified as a loss. Failure, either real or perceived, can also be viewed as a loss. The loss or anticipated loss of anything of value to an individual can trigger the grief response. This period of characteristic emotions and behaviors is called mourning. The normal mourning process is adaptive and is characterized by feelings of sadness, guilt, anger, helplessness, hopelessness, and despair. Indeed, the absence of mourning after a loss may be considered maladaptive. Stages of grief. Kubler-Ross, during extensive research with terminally ill patients, identified 5 stages of feelings and behaviors that individuals experience in response to a real, perceived, or anticipated loss. Stage 1, denial. This is a stage of shock and disbelief. The response may be one of, "No, it can't be true." The reality of loss is not acknowledged. Denial is a protective mechanism that allows the individual to cope in an immediate time frame while organizing more effective defense strategies. Stage 2, anger. "Why me?" and "it's not fair" are comments often expressed during the anger stage. Envy and resentment towards individuals who are not affected by the loss are common. Anger may be directed at the self or displaced on loved ones, caregivers, and even God. Stage 3, bargaining. During this stage, which is usually not visible or evident to others, a bargain is made with God in an attempt to reserve or postpone loss. "If God will help me through this, I promise I will go to church every Sunday and volunteer my time to help others." Sometimes the promise is associated with feelings of guilt for not having performed appropriately or sufficiently. Stage 4, depression. During this stage, the full impact of the loss is experienced, the sense of loss is intense, and feelings of sadness and depression prevail. This is a time of quiet desperation and disengagement from all association with the lost entity. It differs from pathological depression, which occurs when an individual becomes fixed in an earlier stage of the grief process. Rather, stage 4 of the grief response presents advancement towards resolution. Stage 5, acceptance. The final stage brings a feeling of peace regarding the loss that has occurred. It is a time of quiet expectation and resignation. The focus is on the reality of the loss and its meaning for the individuals affected by it. Not all individuals experience each one of these stages in response to a loss, nor do they necessarily experience them in this order. Some individuals' grieving behaviors may fluctuate and even overlap between stages. Anticipatory grief. When a loss is anticipated, individuals often begin the work of grieving before the actual loss occurs. Most people re-experience the grieving behaviors once the loss occurs, but preparing for the loss in advance can facilitate the process of mourning, actually decreasing the length and intensity of the response. Problems arise, particularly in anticipating the death of a loved one, when family members experience anticipatory grieving and complete the mourning process prematurely. They disengage emotionally from the dying person, who may then experience feelings of rejection by loved ones at a time when this psychological support is so necessary. Resolution. The grief response can last from weeks to years. It cannot be hurried, and individuals must be allowed to progress at their own pace. In the loss of a loved one, grief work usually lasts for at least a year, during which the grieving person experiences each significant anniversary or holiday for the first time without the loved one present. Many factors prolong the length of grief process. If the relationship with the lost entity was marked by ambivalence, or if there had been an enduring love, hate association, reaction to the loss may be burdened with guilt. Guilt lengthens the grief reaction by promoting feelings of anger towards oneself for having committed a wrong against or behaved in an unacceptable manner towards a lost loved one. He or she may even feel that the negative behavior contributed to the loss. Anticipatory grieving may shorten the grief response in individuals who are able to work through some of their feelings before the loss occurs. If the loss is sudden and unexpected, mourning may take longer than it would if individuals were able to grieve in anticipation of the loss. Length of the grieving process is also affected by the number of recent losses experienced by an individual and whether he or she is able to complete one grieving process before another loss occurs. This is particularly true for elderly individuals who may experience numerous losses in a span of 3 years, including spouses, friends, other relatives, independent functioning, home personal possessions, and pets. Grief accumulates into a bereavement overload, which for some individuals is perceived as difficult or even possible to overcome. The process of mourning may be considered resolved when an individual is able to gain a sense of organization, redefine his or her life in the absence of the lost person or object, and pursue new interests and relationships. Disorganization and emotional pain have been experienced and tolerated. The individual is able to remember and accept both the positive and negative aspects associated with the lost entity. Preoccupied with the lost entity has been replaced with a renewed energy and new resolve about ways to keep the memory of the lost one alive. Most grief, however, does not permanently disappear, but will re-emerge from time to time in response to triggers such as anniversary dates. Maladaptive responses to loss occur when an individual is not able to satisfactorily process through the stages of grieving to achieve resolution. These responses usually occur when an individual becomes fixed in the denial or anger stage of the grief process. Several types of grief responses have been identified as pathological, including those that are prolonged, delayed, or distorted. The prolonged response is characterized by an intense preoccupation with memories of the lost entity for many years after the loss has occurred. Behaviors associated with the stages of denial or anger are manifested, and disorganization of functioning and intense emotional pain related to the lost entity are evidented. In the delayed or inhibited response, the individual becomes fixed in the denial stage of the grieving process. The emotional pain associated with the loss is not experienced, but anxiety disorders or sleeping and eating disorders may be evident. The individual may remain in denial for many years until the grief response is triggered by a reminder of the loss or even by the unrelated loss. The individual who experiences a distorted response is fixed in the anger stage of grieving. In the distorted response, all the normal behaviors associated with the grieving, such as helplessness, hopelessness, sadness, anger, and guilt, are exaggerated out of proportion to the situation. The individual turns anger inward on itself, is consumed by overwhelming despair, and is unable to function in normal activities of daily living. Distorted grief reactions may accumulate in pathological depression. Mental health and illness continuum. Anxiety and grief have been described as two primary responses to stress. Disorders as they appear in the DSM-5 are identified at their appropriate placement along the continuum. Summary and key points. Psychiatric care has its root in ancient times when etiology was based in superstition and ideas related to the supernatural. Treatments were often inhumane and included brutal beatings, starvation, and torture. Hippocrates associated insanity and mental illness with an irregularity in the interaction of the four body fluids. Conditions for care of the mentally ill have improved, largely because of the influence of leaders such as Benjamin Rush, Dorothy Dix, and Linda Richards. Maslow identified a hierarchy of needs that individuals seek to fulfill in their quest to self-actualization. The definition of mental health is the successful adaptation to stressors from the internal or external environment, evidenced by thoughts, feelings, and behaviors that are age-appropriate and congruent with local and cultural norms. Anxiety and grief have been described as two primary psychological response patterns to stress. Popolo defined anxiety by levels of symptom severity, mild, moderate, severe, and panic. Grief is described as a response to the loss of a valued entity. A loss is anything that is perceived as such by the individual. Kubler-Ross identified 5 stages of feelings and behaviors that individuals experience in response to a real, perceived, or anticipated loss: denial, anger, bargaining, depression, and acceptance. Anticipatory grief is grief work that begins and sometimes ends before the loss occurs. Resolution is thought to occur when an individual is able to remember and accept both the positive and negative aspects associated with the lost entity. Grieving is thought to be maladaptive when the mourning process is prolonged, delayed, or inhibited, or becomes distorted and exaggerated out of proportion to the situation. Distorted grief reactions may contribute to the development of pathological depression.